Hey guys, it's Matt with AEC, and I'm back today to talk a little bit about amiodarone. Amiodarone is an antiarrhythmic that we use a good bit in the job of being a medic. It's something that's been around for a long time. This originally came back on the market back in the early 1960s. This was originally used to treat chest pain, and then because of a few unintended side effects from that, it kind of fell out of use and then fell back into use again now as the antiarrhythmic that we see today. Particularly, it's one of the heavy hitters. It lasts in our body a long time. So there's a really wide range of the half-life of this, but the average is about 58 days, so pretty much 2 months for the half-life on this. So it sticks around for a really long time. And it also works on a lot of stuff. Mainly the channels that it works on are sodium, potassium, and calcium. There on the heart, which we know those are the big three. We talk about depolarization or repolarization, that whole kind of action potential process that we know that goes on there. For the most part, this is really used just for our Y tachydysrhythmias, so we're looking at those AHA algorithms. So specifically, stable VTach with a pulse, we can go ahead and give this. Or unstable VTach with a pulse if that cardioversion didn't work. And then we know we kind of have some doses too for the shockable rhythms in CPR. Contraindications, there's a lot on our pharmacology manual that kind of lists things where it's just really aren't indications where we'd even kind of use them if they're already hypertensive, things like that. But mainly, we need to look out for, once again, high degree heart blocks. Those AV blocks come into play all the time with some of these cardiac meds, so always something to look out for. And also kind of a unique one on this is an iodine allergy. This isn't one that is just absolute, it's just those who have iodine allergies are just at a higher risk of being allergic to this, so it's something that we need to look out for. One of the other things that are pretty unique to this, because we were just talking about using this for VTach, but that's really for monomorphic VTach. We know polymorphic VTach or torsades is kind of its own unique thing, and quite often for that rhythm it causes this prolonged QT interval that can cause that torsades to form. So this is a medication that we kind of want to avoid with torsades because one, it can cause torsades on its own. It can like make that prolonged QT progress into that rhythm, or it can make torsades, if they already have it, a lot worse. So certainly something to avoid when we're dealing with that. Long-term use, because this isn't something that we just have. These are things that people are prescribed and they take daily for different things. So long-term use, some things to look out for. It does put a lot of strain on the liver, so especially if our patients are any stage liver failure, that's definitely going to be worse. Hopefully they aren't still on that medication. And also, this is also something that's pretty chemically similar to one of our thyroid hormones, T4, which is thyroxine. So long-term use of that can also start to mimic, if it's not controlled, can start to mimic like hyperthyroidism symptoms as well. The dose that we're going to have, if they have a pulse and we're using it for a VTach with a pulse, we're going to give 150 milligrams, but that needs to be over time. It's not just like this rapid push. So that's going to be IV, IO. We're going to dilute that into 100 mLs and then give that over 10 minutes. If we're talking about the uses where we use it in CPR for VTach and pulses VTach and VFib, those are going to be IV pushes. So we're going to get IV, IO access. The first dose for us is going to be 300 milligrams and then followed up usually 3 to 5 minutes after that at 150 milligrams. And that's kind of the max that we're going to give, and usually the max that we find on the rigs around. For the peds, it's pretty similar, where we have a weight-based dose like a lot of our stuff, and for them it's going to be 5 milligrams per kilogram.